Medical Consultation Network. Thank you all for being here today. We're very happy to have you, and we've got a real treat for you today because we got some of my best friends here on the phone with us today. We'll get to that in just a minute. I did want to say, well, I'm glad to be back though this week from last week. We kind of promoted the attendance of the START National Training Institute last week. I don't know how many people were able to go to that. If you were, I'd love to hear a comment from you about anything you might have seen or heard on there that was helpful to you or that you liked. And I'm really glad we were able to give you the opportunity to do that. And so today I have as my guests some people from the Harold Jordan Center, one of my favorite places. And, I worked very closely out there with those folks for quite some time. And so I'm glad to have them on here today to talk about interdisciplinary collaboration, which is a topic that is very near and dear to my heart. Very, very important thing that we all need to be working toward because, I was given an example some years ago about what it means to be on an interdisciplinary team. And so there's this idea of several people being blindfolded and holding on to a part of an elephant. And so somebody's holding the leg, somebody's holding the tail, somebody's holding the trunk, somebody's holding the tusk, but they've all got a blindfold on, so they can't see that they're dealing with an elephant, but they all describe the elephant in a different way. And I think that's what happens with interdisciplinary work because a lot of times we're trained in particular areas, so you're trained in behavior analysis, you're looking at, things from a behavioral angle. You're a physician, you're looking at things from the medical perspective, and so you can miss things that contribute to things that have an impact on what you do. So, as an example, medical conditions a lot of times contribute to different sorts of behavior problems. And so, it's very, very good, I think, to be discussing this topic, and very important that we learn about how to collaborate together and to work in interdisciplinary fashion. So I'm proud to welcome today one of my best friends in the world, Mr. Pierre Womble, on the phone, and a couple of my other besties out there, Alicia Massey and Jennifer Osteen. And what I want to start with is to have each of you introduce yourselves a little bit, tell us a little bit about yourselves, and tell us at least one thing that probably nobody else knows. Now, don't give us too much. Just give us what is good here, what's fine for everybody to hear. So we'll start with the leader of the pack, Pierre Womble. Pierre, welcome.
Thank you. I appreciate it. So I guess, I'm Pierre. I've been doing this work for quite some time. And the one thing that I guess folks don't know is I'm a pretty avid fisherman. I love to get out on the water every opportunity that I can.
Okay. That's cool. So, what got you like doing freshwater fishing, bass fishing, or?
Bass fishing, crappie, big mouth, small mouth, anything that'll bite most days, though.
All right, that's good. Appreciate that. And so then we also have on the phone with us, or on the line with us, Alicia Massey. Alicia, tell us a little bit about yourself.
Hi, I'm Alicia Massey. Let's see, something that people do not know about me is that I have lived on the East Coast, the West Coast, and the South in the span of 12 years. And I'm just 21.
You're just 21? Excellent. Amazing. Now, that's good. So you're on the East Coast and the West Coast. All right.
Yeah.
That's cool. So where on the West Coast? Los Angeles?
I did live in Los Angeles County. I lived in the San Fernando Valley. You remember the show The Valley Girls? They used to come a long time ago. Yeah, I lived in that valley for a number of years.
Okay. So you could understand that when they talked that weird way they talked. Did they really?
Sure, yeah, just a little bit. I could have been, I don't know now, but I could have been when I was there.
And remind me what your role is at, or not me, but remind our audience what your role is there at the Harold Jordan Center.
I am the program specialist for the Behavior Stabilization Unit and the Forensic Assessment Unit here at HJC.
All right. And then we have with us also Jennifer Osteen today.
Hello.
Jennifer,
I'm trying to think of a random fact, and I'm really struggling with that.
well, first tell us about what you do at HJC.
So I'm the behavior analyst here at HJC. I've been here almost 4 years now. Let's see. Still trying to see something to tell you guys about me that nobody else knows.
Well, where are you from?
I'm originally from Ringgold, Georgia, right underneath Chattanooga, Tennessee. Went to school in Alabama and then made my way up to Tennessee.
Where was that? Jacksonville State. Is that right?
Jacksonville State.
All right, cool. So what's something you're interested in? What type of music do you like?
I like an assortment of music, typically more alternative, maybe. I know you know that he followed the Flaming Lips for a little while. That was
The
really
Flaming
fun.
Lips. Yes. That's also one of Michelle's favorite bands, I think. Is it? No? Okay. Well, all right.
I don't know that I've ever heard their music, but I'm not against them. I just haven't heard them.
Oh, okay. Well, I appreciate you guys being here today. This is great. Now, before we launch into the topic, I did want to ask you about a recent experience I know the three of you had. And you have all given, well, I'm not sure if Jennifer gave you permission to talk about this, but I think she did. That you got tested for COVID. And I'm just interested in your experience with that. What was it like getting tested? Because I think a lot of people are probably, I don't know, a lot of people probably kind of recoil at the idea of having to have a swab, a Q-tip stuck in their nose. And so, I don't know, can you guys describe a little bit about what it was like to get tested?
Yeah, so I'll jump in. I think for me, it was a little bit of anxiety a couple of days before knowing that I had to do it. But on the day of the test, we walked in and filled out our initial paperwork, and then the nurses asked you to blow your nose, clean your nose, so that I guess they can have a clear path to where they're going. So you blow your nose, and then you sit down in the chair, tilt your head back, and they insert this 6 or 8 inch Q-tip, maybe even longer, 10, 12 inches, into your nose. Now, not all 12 or 6 inches goes into your nose, obviously, but you know that they have done it correctly the moment your eyes start to water. That's what I remember the most is they go so far back up your nose that it makes your eyes water. And then, they have to swirl it around a couple of times and then bring it out, put it in a vial, break the tip of it off, and then that's it. So the most uncomfortable part about it is obviously more uncomfortable and painful is just once it's back in the position that they need it to get in, it needs to stay there for a little bit and they kind of swirl it around. That's a little bit uncomfortable and makes your eyes water. But overall, it wasn't too bad of a process.
But you had to get it twice.
I had to get it twice. My first test came back inconclusive, and so I was not only having to worry about doing it again, I'm now, anxiety ridden because I don't know what this inconclusive result means. So it was a long night last night, needless to say.
But you came back negative after all was said and done. So that was good. And then, Alicia, how about you? What was your experience like?
I would like to hear, I had the anxiety of wondering what the actual test was going to be like, the process. But I was told by someone who had already had the test before me that if you swallow while they're swirling, that it helps to relieve the pressure. That helps a little bit. I think just the whole thought of that swab, and I'm looking at this long piece of Q-tip coming toward me, and it really made me think I was a needle. I just have to, because I don't like needles either. But once it was done, it was over, and I was thankful that I did not have to repeat the test. I don't know how I would have reacted to that one.
Yeah. Okay. How about
swallowing just a little bit.
Swallowing a little bit. That's your advice. Okay.
Yeah.
And Jennifer, how about you?
I definitely agree with them. There was a lot of anxiety leading up to it. It was definitely uncomfortable. Not something I would want to do again, but it definitely wasn't as bad as I had imagined.
We're initiating a statewide testing program, essentially, and so our aim is to test everyone statewide, all persons supported statewide. We won't be testing all staff statewide. But this is going to be really uncomfortable, but yet a lot of people who do it. And I appreciate that you guys were able to share those stories a little bit. As folks start taking the test, then, that they can maybe share a little bit of what you experienced and how you got through it to be able to help others want to do it. So we're going to have several testing opportunities for people statewide, and information about that will be coming out very soon. But I want to shift to this topic that you guys had for today's consultation, and that's all about interdisciplinary collaboration. And I don't know who's going to start us out talking about this, but can one of you jump in and introduce? Are you going to do this, Pierre, or will it be?
Who's going to? I thought Jennifer might lead us off.
All right.
All right. So here at the Harold Jordan Center, we do follow an interdisciplinary approach. I'll kind of go through some of the disciplines we have on staff here. We do have our program specialists. We have 4 of those right now. They kind of cover case management, employment, vocational, incident management, kind of everything, the day-to-day stuff here. We also have a medical team. We have a doctor, nurses, our psychiatrist, Dr. Schuler. We have a psychologist, behavior analyst, mental health therapist, and speech therapist kind of covers all of our clinical field. We also have rec therapists, counseling associates, our supervisors, and of course our CSPs. So we do have a really great team here to collaborate.
Yeah, I see you have, we have Dr. Schuler on the phone with us too, so hopefully he'll be able to weigh in and comment a little bit on what you had to say today. Mm-hmm. That's great. Yeah. So tell me a little bit more about how you work together.
Well, when we're running our typical day-to-day here without the COVID restrictions, we do have our weekly meetings with our teams to kind of get updates on progress that everybody's made. And if we have a new admission, we'll be talking about our assessments, our goals for those individuals. We then move on to the progress that's been made by them, anything that we need to change, update. It's really important that we have that medical side as well as the programmatic side represented in those meetings so that we can make sure everybody's collaborating just kind of on the same path.
I would also say, Dr. Davis, is that, as you well know, the folks that we work with at the Jordan Center, they come with some really complex presenting problems. And the more people that we can have at the table as experts in a particular area to give us a picture of what they're seeing from their discipline, the better we're able to put together a treatment plan that ultimately will lead down the road to that person's success in being able to live and back in the community successfully. So this is, every single person on the team who has an expertise or has an eye to observe, we want to hear what you have to say so that we can all kind of take that piece of information and put together this puzzle. And it's so interesting the number of times, and as you've been out there and seen this happen, it's so interesting the number of times that a little small piece of information sometimes can make the difference in getting us started down the right track to put together a treatment plan. And so we're very fortunate that we do have a rich complement of professionals and experts to help make up this team to kind of get us down the road. I would also, I would be remiss if I didn't strongly emphasize the importance of our direct support professionals in this process.
Yeah.
The information that they have is vital, critical. It's most of the time it's relevant, it's right on point, and so they are perhaps the most critical piece in the process and the teamwork that we're doing.
Without them, none of the information that your team puts together gets implemented.
That's right.
Yeah, that's a very important piece of it. And likewise, they've had an observation from a perspective, as I was talking about these perspectives that other people on the team don't have. And so that is a real important thing that you're bringing out. I think, there's been a lot of discussion about it, but DSPs are essential, to all of this. Nothing happens without them.
Absolutely.
So that is, I'm so glad you brought that out. So tell me more about how, maybe some different cases or something that you've worked with and where the interdisciplinary process. I'm going to highlight one other thing that you said there, because assessment is such an important part of everything that we do. I am, I feel like a lot of times we're trying to solve problems before we really understand what the problem is.
Mm-hmm.
And until you kind of get that little nugget, you were talking about that thing, maybe just a very small thing that really helps you move to the next level, you're kind of shooting in the dark. It's sort of like we're trying a lot of things, but we really don't know what we're dealing with, so we can't understand how to intervene.
Mm-hmm.
And so maybe, I don't know, do you have any case examples, or I don't want to interrupt the process here, however you're going to go through it, but is there some other things there you want to discuss?
Well, you mentioned the assessment piece, and the process, and I guess the model, if you will, that we have developed out there, we refer to it as a resident continuum, and this is how we've used every resident that comes to us. They kind of matriculate through this continuum. And the first step in this process is the assessment phase, where when they come to us, every single discipline is working to complete their assessment so that we then can figure out what the responsibilities, what their actions, and what are the goals of the staff person. Once that assessment and that information is complete, what are those responsibilities, actions, and goals that we need to be working to move that person through to the next step? And the assessment piece, as you mentioned, it's ongoing. It starts day one, but it can be ongoing for the whole time that the person is there with us. We're constantly trying to learn. We're constantly trying to pick up on little nuances that we can tweak our plan. And so that assessment is something that we're doing pretty much all the time. And like I said, every discipline, Dr. Schuler is doing his work in the psychiatric vein. We have a licensed professional counselor, will have, that will be doing it there. The BAs are doing their assessments. program people are doing their assessments, like therapists. Everybody is kind of working to gather information from their little corner of the world. And then once that phase, we think that we have enough to get started, then we get started implementing a plan that we work together to put in. The interesting thing, though, is that all of our residents at some point, we move to the second phase of our continuum, which is that crisis phase, where they have some kind of a event that, they go into crisis, they act out or whatever. And even in the crisis phase, we're still trying to figure out what can we learn. And then, if everything is good and we've got a period where the person is not demonstrating crisis behavior, then we start to view that person as being in the maintenance phase, where the plan that we are implementing is working. The person has started to level out a little bit. And in the maintenance phase is when we really start to look at how can we start to open up the world to this person? What new experiences can we now bring to this person? Because we're not so concerned, we're always concerned, but we're not as concerned about taking the person out into the community and worrying about it being a disruptive, event. So in the maintenance phase, we start to explore the world. We get them out. We do volunteer work. We're doing anything and everything that we can think of to try to expose this person to new experiences and new knowledge or what have you.
And the exposure piece seems to be important because, I think a lot of times that when we're working with somebody, particularly has, behavioral issues under certain conditions, a lot of times we want to try to avoid those conditions, but that really impairs their learning about them, doesn't it?
Yeah. It absolutely does, because one of the big challenges that we face in terms of transitioning people from the Jordan Center is this idea that, they're behaving well in the Jordan Center. That's great. And this is the provider's perspective, right? They're behaving well in the Jordan Center, and that's great and wonderful. But what about when they come back out into the community? And so we want to try to expose them to as much community stuff so that we can demonstrate to the provider, well, we've done that also, and here's the plan to make that piece work, right? And so as much as we can expose people to, it makes the transitional phase go so much better.
Yeah, I can see that. And so transition, such a key part of what you do there, Harold Jordan.
Yes, that would be the fourth prong on this continuum, that in the transitional phase, we're working with the provider, we're working with any and every stakeholder that we can think of to help prepare the provider, the individual, for discharge and transition out into the community. And we've done some interesting things. Jennifer and Alicia have been really integral in some of the things that we've done. But we've done things, obviously we'll bring the provider in to do cross-training. And Alicia is very involved in getting that set up. We'll do that for as many days and many hours as we can. We want the receiving staff members to see the plan in action by our staff members. They have an opportunity to be trained. They have an opportunity to observe. We've even taken the person to the new residents for a few hours of a day to let them get adjusted. So all kinds of things that, we've been able to creatively do to help foster the transitional process.
So, Ms. Massey, Alicia Massey is involved in that transitional process. Alicia, can you tell us a little bit about some of your experiences as coordinating these transitions and things that were really important?
I think, like Terry said, one of the main things is making sure that the staff that will be supporting them in their home is very familiar with the person and what we have learned about them. ensuring that they come here to the center and they cross-train and they visit and they shadow our staff, as well as our staff going to the home and assisting when the person moves is a key component in making sure that there's success. One thing that Pierre didn't mention, post-transitional, we will also go back and assist if needed once the person is out. If they are the staff are running into some problems or things just are not working out for them, we will go back and offer our assistance. We will observe, we will retrain if necessary, just to, try to make sure that that person is successful in their home.
That's great. And so when someone goes in, you'll sometimes have the staff that worked with that person directly to go out with them and basically model some of the things that have been successful for the person in that person's new home.
Exactly. And if they are not staying in the Davidson County area and they're moving to West or to East Tennessee, we would even arrange for our staff to stay a few days in the area so that they can be there with the staff. We actually had a case a few months back that transitioned out, and although the staff were there, they had to go. We sent them back, and we sent them back for 3 days so that they could help the individual, the person, really be comfortable with the new staff and have a smoother transition and maintain communication with them to this day. So that, we just want the success for the agency and the person, and so we do everything that we can on our end to ensure that happens. If it's cross-training again, if it's just visits, if it's phone calls to that person to let them know that, hey, you're not forgotten, then we do that as well.
So it's not just about the training, though. It's also about just a transitional, improving the comfort level of the person and the staff and helping them get to know one another.
Helping them to build that relationship.
Yeah.
That's so important.
Yeah.
They need that relationship.
Yeah, that's key. And it's hard to build that in one day or even a few days, but if you have somebody there who, it's kind of like when you get introduced to somebody new, if you just meet somebody new out on the street, it's a little bit more awkward. But if you know somebody who knows that person and you get introduced, it's an easier transition that you make into friendship. And the same thing applies with the folks that we're serving here. So Jennifer, tell us a little bit about your role in all this. And I know one of the things you do at the conclusion of a person's stay is that you coordinate a interdisciplinary assessment for that person. And can you tell us a little bit about that process and a little bit more about what you do?
Yeah, so with the interdisciplinary discharge summary, that's a document that we provide at discharge. All the disciplines here will fill out just kind of a summary of the person, what has worked for them, what hasn't worked, any recommendations that they need to have continue in the community setting. I think that's a really helpful document to follow this person out. Behaviorally, I will update the behavior support plan if they have one into a community support plan. They can follow them out until the VA and the community has done their assessment and their plan. We'll do any recommendations, do any HRC work that needs to be done on the front end before they move. Alicia and I have both gone out to the houses that the individuals will be moving to just to kind of make sure that that's going to work for them. We look for little things that people might not think about, the glass on the windows or a hook that might be on the wall, things that we know these people might struggle with when they first move, so we try and help them out with that the best we can.
Look for environmental things that might contribute to difficulties for them. You were talking about the discharges that you've had. Maybe this would be a question to everybody on the panel here. What have been some of your more notable successes?
I think we've had a ton of successes that, we don't always expect everybody to be successful when they move out. But there's been a lot of surprises, and I think that can fall back to the training that we've provided and just the support from our staff to go out and help. And just that whole cross-training process really helps that out.
Yeah. Is there anybody in particular that maybe you would describe that you feel like did well after their life? And it doesn't necessarily have to be did well, because, one of the things I think is a little bit of a myth is that people come into Harold Jordan Center to get fixed. I'm not sure that that's always the outcome. Sometimes the outcome is just understanding the person better so that you can support them more effectively in a community setting. So I don't know. Is there a particular person that you've had that you feel like would be exemplary of that?
I know for me, I joined this team back in 2014, and the first real challenging person that I met was this young man that had been at the Jordan Center for a pretty long time. Very large African American man who would break doors and damage property, and he was just really, really destructive, and we couldn't get traction with him. And through the process of this interdisciplinary team, we started to learn some interesting things about him. That there was this period of time that he would psychiatrically kind of start to cycle. And it was so interesting to me to hear all of the pieces of information come in, like, okay, when he is saying this thing today, or when he is talking about this thing today, or when he is referring to himself or others as that. All of those little nuances, through the process of time, we developed a pretty good approach with him. Now, as you said, it did not fix him. Dr. Schuler was very, very involved in this case and very integral in helping to get a plan together with that. But we didn't fix him, but we did bring him to a point to where we were able to successfully discharge him, set up an arrangement with that provider that if these things happened, a very detailed, I don't even know what to call it now. I know we had a fancy name for it then, but
Warning signs.
Right here you are, or warning signs.
Yeah.
These are escalating for him.
Yes. If you see this, do this. If you see this, do this. All the way down to if he does this, call HJC, we'll come out and we'll assess him. And we even had a plan in place where there was a process whereby he could be rapidly readmitted back to the Jordan Center. And that transition has happened now, I know, well over a year, maybe even 2 years ago.
Right.
And we've had to bring him back maybe once or twice. And we've gone out to see him maybe once or twice, but he has done really, really well since his time with us.
Yeah, it was an acknowledgement or an acceptance that he had, and I believe, if I recall correctly, that man's diagnosis was bipolar disorder. And so he's being treated for that. Dr. Schuler prescribed treatment, but periodically he needs adjustments in those medications. He needs just a period to stabilize. And so he would get into manic phases where it was very difficult to manage those things. And it was, what I liked about the crisis plan for that guy was that there was an acknowledgement that this is just a piece of the furniture. I mean, we're going to continue to try to treat this and do the best we can, but this is something for him that is periodically going to occur. And so we're not going to treat it like a crisis. We're just going to have a plan for what we do in that circumstance. And that plan, I think, has made all the difference in his success in the community, is to have that backup at the Harold Jordan Center.
Right.
And the key thing. I don't know, Dr. Schuler, I know you were on the line. I don't know if you want to come in and comment at all on that particular case that Pierre brought up there.
I believe I know the case that you're talking about. Can you hear me, Bruce?
Yes, I hear you. I hear you. You hear me? I heard you.
I've lost connection.
Okay, now you're in.
Bruce, nod your head if you can hear me.
So I can hear you.
Okay, I can't hear you at all. I don't know what happened. But no, I believe that, nod your head when you want me to stop too. I believe I understand the person that we're talking about. You know, what was interesting, it's so easy for me to be a psychiatrist at the Harold Jordan Center because you have a wide array of staff that can kind of give you feedback. And it got to the point where this gentleman, the staff knew his symptoms so well that even when I was at home, they gave me a call. They could kind of tell me exactly where he was at, and we were able to make adjustments to his medication based on that. So when you get to know people that well, where all of your staff know the symptoms, they can call me and tell me, and I'll know what's going on. What ended up helping this gentleman was starting him on medication, clozapine, which a lot of people aren't able to use because it really involves a system to support that individual getting started and continued on it. And that's a benefit of the Harold Jordan Center. You know, you can't help people in a 4 or 5 day admission. And luckily we had a lot of time with him where we could easily adjust his medications as he needed. And then even when we discharged him, you know, we would get a few calls, and sometimes we'd find out that other people had lowered or changed his medications. Given the fact that we knew him so well, we could say, well, you know, I think you need to start this back or increase this. So it ended up helping him tremendously.
Well, I realized I nodded there, and then you probably just stopped because I nodded, but I was disagreeing with you. So that's good. Good input from the psychiatrist. You know, that is one of the things. Dr. Sheila, maybe you could just comment on this just a little bit, if you would, if you can hear me. Can you hear me now? I'm not sure if you can, so I'm going to go ahead and comment for you. Can you hear me, Michelle? Okay, just checking. Basically, what I want to say about this is I think psychiatrists really appreciate having this interdisciplinary team around them, because so often people go into the psychiatrist's office and they say, fix this person, please do something about it, you know, and the psychiatrist has got all the pressure on them, and so they start prescribing medications. And then when those don't work, they prescribe a few more medications and a few more and a few more. And one of the things Dr. Sheila really does is try to right-size that medication regime, narrow it down to those, you know, optimize it, get it down to what is most helpful for the person. And then, you know, let the rest of the interdisciplinary team do their part in this. And when you do that, you come up with a much better solution at the end of the stay than you would otherwise. So that's fantastic. I don't know, anybody else out there, the other team members want to comment on what it's like to work with Dr. Sheila in that regard?
I'll just say, in piggybacking on your comment, there has been a number of times where that exact scenario has happened, where staff will say they're doing X, Y, and Z, and then call Dr. Schuler to fix it. And the number of times that Dr. Schuler has been able to say to that person, this is not something that medication can fix, has been so informational and such a springboard for us as the leaders and programmatic people to reemphasize to the staff person, if it's not going to be fixed by medication, it's going to be fixed by implementation of this behavior support plan, treatment plan, whatever it is. It gives us leverage and a springboard to be able to better train our people as well. So that scenario has been really, really helpful many times. And pushing our staff, and I'll just say, you know, away from using medications as being a crutch to fix the problem.
Right. Well, you know, what happens many times, you get all those medications on there, and you're still dealing with a serious problem.
That's great.
Yeah.
Hi, this is Esmeralda.
Yes.
Hi. So from a medical entity standpoint, I can honestly say I agree with Pierre that Dr. Schuler typically will say, hey, can we rule out any medical cause before we move on to anything else? And so, being an NP for both places, a lot of times, it forces us to go back and reevaluate, is there indeed a medical reasoning for the behavior, which in the normal world you would do that. So it really puts us in a position to really search and make sure that it's not medical. And then the other thing is, it could be behavioral, and so we're glad to have, our VA on board too, because it's not a quick fix, and I know nursing will call us and say, can you prescribe something? No, this is not a pill form of a thing. So Dr. Schuler has been kind enough to grace us with his presence on that side too, to say, this is not a quick fix, people. It's going to take a little time and a little sorting out. So I'm appreciative of that.
Yeah, that's not always the most popular thing, but Esmeralda, so you're the nurse practitioner out there, meaning that you provide some of the primary care for the folks at Harold Jordan Center. And you mentioned that sometimes you'll search for that underlying medical condition that, contributes to whatever presentation the person has, whether it be mental health or behavioral or just, discomfort of some kind. Are there any examples of circumstances where you've had to kind of do some digging to find out what was going on with somebody medically and how that explained a lot of what was going on with them? Whatever types of behavioral issues they may be having?
So a lot of times we've had to go, for example, if there have been, they might have a UTI, and so they're reacting to that. Their thyroid levels could very well be off, which is creating a lot of anxiety. They're having seizures, so maybe their Kepler or lamictal level is off. Maybe they're having blood pressure issues, and so there's a lot of things that you have to factor when they're saying, are they behaving in a different manner for which you and I could say, my head hurts.
Right.
Or I can say, I've been having this, where the challenge with our population is that you really do rely on the interdisciplinary team, and especially the direct support staff, who know these people very well, to tell you, hey, this is not normal, this is not this, and this is not that. So it behooves us to, from a relational standpoint, to have a great relationship with not just medical, but with the VA, the direct support staff, those people who have known them for quite some time, are able to speak to things that I'm not in the home 24/7, but they are. So that just helps a lot. If they're having a fever, what's the cause of the fever? Fever just doesn't show up on the scene for no reason. There's an underlying cause. Nausea and vomiting, there's an underlying cause. Constipation, what's the issue? There's an underlying cause.
Oh, that constipation issue you brought out so often is a factor, in particularly when people who don't communicate well are having problems. That's one of the first things to look at. And so it's, of course, important to have a primary care practitioner there who can look into that, maybe literally in some circumstances, to make sure that issue gets addressed. Because if it's not, then you might still continue to have problems and treat it in a different way that's not going to be very effective. So that I'm really appreciative of that input there from the interdisciplinary perspective. Well, I just really kind of I would allow anybody to come in and ask any questions that they may have of the group about interdisciplinary work or different experiences they may have had at the Harold Jordan Center. Does anybody have any questions they'd like to come on and discuss or ask?
You can also put your questions in the chat box and we can read them for you if needed.
I see Stephen Bell has described in detail about his testing experience, COVID testing experience. So, well, Pierre, team, I would just ask you in closing, are there what kind of capsule summary this for us? What makes Harold Jordan Center so great?
I think, in my opinion, we've been able to put together a team of people that don't mind asking questions and digging up into the root of the problem. I think additionally we have a group of folks out there who really care about this population and trying to solve and make life better for the folks that we work with. And one of the things that we always say, or that I always say in terms of our team, we may not get it right every time, but we're not going to get beat at trying. We're going to be trying every single day. We show up to work to figure this thing out and make life better.
The only way you get beat is to give up.
That's right.
And that's the thing. I think that's what you're saying. You don't really give up at Harold Jordan Center, and it doesn't matter about all the fancy degrees and everything. It really matters about how persistent you are in trying to understand that person. That's the key thing.
We have some questions in the chat box. You want to cover those?
Yeah, there were a couple of questions that were added while we were talking there, Pierre. Describe the type of patient that's appropriate for referral to HJC.
Yeah, so we generally work with people that are high utilizers of resources, a high utilizer of perhaps legal or police involvement, people who have a lot of aggressive tendencies, property destruction. Generally, it's the highest utilizers of services in the department.
Yeah, you have a forensic services unit there that serves people who have charges against them, who and they've been found committable, meaning that because of their intellectual disability, they're a risk of harm to self or others.
Right.
They can't stay in whatever environment that they're in, and so they're committed to Harold Jordan Center. But they have to have active charges to come in under that program. Right?
That's correct.
And then you also have the behavior stabilization unit that Alicia spoke of, which is more or less somewhere that people can voluntarily go to kind of get things under control. So like you were talking about the fella earlier, it comes in for a period, he's stabilized, and then he returns to his home environment. And then for a little bit longer stay, you have the ICF unit, or the Day One program.
That's correct.
Yeah. So those programs are really important. Now, you've had a little bit of difficulty admitting people recently because of some staffing issues and other things of that nature, but are you starting to come out of that now? Do you see yourself moving in a positive direction?
We are moving in a positive direction right now. Obviously this virus has placed a lot of people out of work, and so we've been able to capitalize a little bit on that and get some positive momentum in terms of hiring and recruiting staff members. And so we expect to be able to increase not only our staffing census, but also our census in terms of people that we can serve in the near future.
We got a few other questions in the chat box. One person wanting to know what the admission process is, and there was another question, if there are any long-term placements at HJC.
So there are no long-term placements in HJC like forever placements. Some of the placements do go longer than others because the person is not stable. We're still trying to figure it out. Provider has backed out a variety of reasons, and things might happen that would extend a person's stay at the Jordan Center. Typically, though, for our stabilization unit, we're trying to discharge people anywhere from 45 to 60-day period. The forensic unit, those typically are longer stays because we're working in conjunction with the court for final disposition of their charges, and our psychologists doing the competency training and the committability assessment. So the forensic unit can be longer because it's an extension of the court. The ICF unit, it is longer stay as well in comparison to the BSU, but we're trying to, the goal is to discharge people from that unit in a 6-month to a year time period as well. So there are, the ICF unit is a little longer stay than the others, but none of them are forever placements or long-term more than a year. So.
We had one other comment. It wasn't a question, to just say that they've attended several discharge meetings and are very impressed with interdisciplinary participation at HJC. They think it's a great process, and they just want to say thank you and kudos to the staff.
We appreciate that.
That was Kathy Felton that sent that message forward. So, well, Pierre, thank you so much. And Jennifer, Alicia, Dr. Sheeler, thank you all very much for coming on and being with us today on the Clinical Consultation Network. You guys got a great thing going out there at Health Jordan Center. I'm just very excited about all the things that you do, and I'm excited about what we're going to do going forward with the assessment stabilization teams and the collaboration across the community with Harold Jordan Center, and as we're able to get our staffing corrected and, back up to speed, that we're going to be able to admit people in the near future in a way that we haven't been able to do in the last period. So I am so happy. Thank you so much for you guys coming on today and telling us all about your program. It's wonderful. And we do this every Tuesday on the Clinical Consultation Network, 12:30 p.m. Central Time. Join us every Tuesday for this, and we will continue to have good guests like the folks we've had from Harold Jordan Center today. Thank you all for being here.
Thank you. Bye.